Welcome everyone to this new batch of FRCS urology training. We have a trainee who is going to discuss the scenarios on prostate cancer, and he has kindly agreed to record the session so that it will be a good revision source on the later date. Thank you. Your time starts now.
Thanks, Mr.
You have a 65-year-old gentleman referred by GP for increased PSA at 5.9. How will you proceed?
I would see this gentleman in my cancer referral pathway cancer clinic with CNS nurse and with a urine dipstick analysis on arrival, if possible. I would take a detailed history on his lower urinary tract symptoms, concentrating on any red flags, hematuria, dysuria, and any new onset of erectile dysfunction. I would check for any systemic problems like anorexia, weight loss, bony pain, and also would like to establish why the PSA was done initially. I would go and take more about his medical history, medication if he is on, especially considering the fitness for surgery if required in the future. Take history on surgical history, concentrating on any urological surgery underwent before, and any recent history of recurrent urinary tract infection and radiotherapy in the past as well. I want to get more information about his family history of prostate cancer or any other urological cancer, and I would go and examine the patient with a chaperone. And during the general physical examination, I would want to check his abdomen, suprapubic region, external genitalia examination, checking for prepuce and external urethral meatus, testicular examination, and a DRE for digital rectal examination for prostate, noting on the size of the prostate, abnormality or nodule on the prostate, anal tone, and saddle anesthesia. I'll complete my examination with neurological examination.
Okay. What are all the criteria for which the patient has to be referred from GP?
According to the new NICE guidelines of 2019 and 2021, I understand if there is a PSA raise according to the age-specific range, any abnormal DRE or any systemic signs of prostate cancer, he should be referred. Also, I understand that EAU guidelines also mentions about the PSA arrangements. If PSA can be done in patients who are more than 50-year-old and with well-informed and high-risk patients, 45-year-old and more with Afro-Caribbean descent and family history of prostate cancer, and anybody more than 40 with BRCA gene mutation can be assessed for PSA, and if abnormal can be referred.
What are all the conditions in which the GP needs to measure PSA test?
GP, as per NICE guidelines, it's any new onset lower urinary tract symptoms, any visible hematuria and erectile dysfunction.
When will you label a patient coming to your clinic? By chance, if you are diagnosing cancer of the prostate, you will label it as hereditary prostate cancer.
There is a specific definition for hereditary prostate cancer if 3 first-degree relatives are involved or 2 relatives are involved less than 55 years.
Okay, what is the risk?
If 1 relative is involved, risk is twofold. 2 relatives are involved, it's 5-fold, and 3 relatives are involved, it will be 11-fold.
What is the gene associated with prostate cancer?
There are multiple genes involved. The main important gene as of now is BRCA gene attached to chromosome 13 mutation, and other genes which can be highlighted here are HPC gene chromosome attached to chromosome 1, and I think another is MSR gene attached to chromosome 8.
Okay, so as I said, this patient presented with PSA 5.9. Examination showed normal prostate measuring approximately 50 cc, no suspicious nodules. no neurological findings, no other urology issues. What will you do now?
According to the new EAU guidelines, I would repeat the PSA again just to make sure this PSA is not just one-off. And if the PSA is abnormal, I'll go ahead and book a multi-parametric MRI scan with a view of biopsy, prostate biopsy. If this is abnormal, I'll counsel the patient accordingly. And if this is abnormal, I'll ask the GP to repeat the PSA and refer back if the PSA in the future goes above age specific range.
So when will you repeat the PSA test?
Ideally, it should be 4 to 6 weeks. There is no hard cutoff time, but I would repeat in 4 to 6 weeks time.
Okay. Is there any problem when you repeat the PSA test in the same clinic?
No, I can repeat the PSA in the same clinic, but I would like to know when was the previous PSA done, or was it associated with any lower urinary tract symptoms, especially during the UTI time. So I would want that to, if it is associated with UTI, then I would like to get a repeat PSA about 4 to 6 weeks after.
Will your examination of the prostate DRE affects the PSA test?
Generally it wouldn't. Previously it was thought that PSA affects, but I know that PSA raise is about 0.25 nanogram per deciliter after a digital rectal examination.
How will you decide the normal levels for a patient?
It is based on NICE guidelines and also Osterling's criteria. Osterling's criteria, published in 1998, showed the age-specific value of between 40 and 50 PSA of 2.5, 50 and 60 PSA 3.5, 60 and 70 4.5, and 70 and 80 6.5.
Okay. What is your view on prostate cancer screening?
Prostate cancer screening, as per UK, there is no national set guidelines for prostate cancer screening, and this is based on multiple studies before. It is still controversial. However, at the moment, it is opportunistic screening. I would like to highlight few studies at this point, which is a PLC or study from US, CAP study from UK. Which did not show any, both of them did not show any cancer-specific survival or overall survival. However, there is a study from European study, which is ESRPC study. It has come up to 16 years now and has shown advantage in screening, especially when number needed to diagnose has come down from 13 years to 16 years, which was around 700. Now it is 500 odd. And the number needed to invite to rule out a death from prostate cancer is 18, which has come down from 26.
Okay. Do you know any UK-based concepts in this?
UK-based prostate cancer risk management group has now advised about opportunistic screening, which is screening in people who are at high risk, which is more than 50-year-old, well-informed and with high risk of prostate cancer. Any patients more than 45 with African-Caribbean descent and family history of prostate cancer, anybody more than 40 with BRCA2 gene mutation.
Okay. Is there any studies which showed any drugs which is effective in protecting the prostate cancer?
There are multiple studies which involve selenium, vitamin E, and multiple. I don't remember the name of the studies, but those were the studies which involved and did not show any major advantage in involving these medications in preventing prostate cancer.
Okay, so this patient's baseline PSA is 5.9, repeat PSA is 6.3. What is your next step?
This patient has got high PSA according to his age-specific criteria. I would go ahead and arrange for a multi-parametric MRI scan after counseling the patient. And depending on the MRI scan results, if there is any abnormal report, then we'll book for biopsy of the prostate. I would accordingly counsel him, tell him about the types of biopsy that needs to be done as well at the same time.
Okay, at any point you will not do the biopsy based upon the MRI?
Based upon the MRI, if it is a PIRADS 1, PIRADS 2 lesion, along with the PSA density less than 0.15, and that ideally these and the DRE, if it is normal, then I would defer the biopsy and I will put him on PSA monitoring.
Okay, so it's time's up. It's 10 minutes. Good presentation, Sachin. No major concerns. We are quite in the early stage of the exam days. You have almost a month to go. So I think you will get only better from here. I have no major problems or no major concerns as such. If I get into quite in details of what you have said, you have included the cancer nurse specialist in the initial stage of 2-week wait clinic PSA referral itself. Actually, it's not necessary. So cancer nurse specialist for increased PSA is not necessary at any disease, whether it's renal cancer, bladder cancer, testis cancer. The cancer nurse specialist comes into play only when the cancer is proved. Okay. So when the patient presenting with PSA, you don't have to include the cancer nurse specialist. Cancer nurse specialist comes only after the biopsy, if there is a positive biopsy, or if there is something like PIN or high grade PIN ASAP, you can include them just for the sake of completion. In case of visible hematuria, if the flexi shows a cancer, you can include them straight away after the flexible cystoscopy. In case of renal cancers, if the CT shows a lesion, you can include them. In case of testicular cancer, again, the cancer nurse specialist comes only after orchiectomy. They can help you sometimes to chase the results, etc. But there is no real role for them, especially with just 2-week wait PSA referral, because then the number of patients they will be involved will be too much. In the initial presentation, you have not mentioned about ethnicity of the patient, but later when we discussed about how will you decide the significant PSA level, you brought in ethnicity also. You can bring in the breast cancer because the BRCA genes are also linked with breast cancer. Whenever we are discussing hereditary prostate cancer, you can say that I will ask, is there any history of breast cancer in mom or grandma, or even the maternal history also? Nothing wrong in it. But if the examiner asks you why, you should be able to come out that BRCA gene is a common gene for both breast cancer and prostate cancer. And regarding that 4 to 6 weeks gap for the second PSA, maybe bookishly it is correct. But if you see how the NHS works, the clock ticks as soon as the patient referral is received. So if you are really waiting by the calendars 4 to 6 weeks for your second PSA, the patient will breach. So in practice, even though patient had PSA with GP, usually we'll try to do the one more PSA in the clinic visit itself. And you are correct in waiting for second PSA test before jumping into any test. That's correct one. But waiting for 4 to 6 weeks is theoretically correct, but practically, at least in NHS, some examiners may question you that your patient is going to breach. So you need to be a little bit practical also. So you will be judged on your raw theory knowledge. How are you applying it clinically, and how is your communication and overall presentation? So for example, if you take this point, you are scoring good in your raw theory knowledge. But clinical application wise, the examiner may question, is he really waiting for 6 weeks for the second PSA? Then what will happen if it is increased? Then there will be more delay and more breach. Or if you want to be more scoring points, you can say like, by the guidelines, I need to wait for 4 to 6 weeks for the second PSA test. But because of the 2-week wait pathway, I will do the PSA test in the clinic visit itself. In that case, you are ticking your theory knowledge, you are ticking your clinical application also. Communication wise, overall you look good, so I have no concerns regarding that. And there is no other major concerns. And regarding whether PSA will increase with the presence of DRE, you can bring out that DRE may increase the PSA up to 0.26 nanogram per ml, but it's not significant. And unless if there is a significant prostatic massage done for any other reason, there is no contraindication is doing the PSA test immediately after DRE. You brought in ERSPC little bit more points, maybe because there may be a scenario where the examiner will just ask only the PSA screening and complete the whole 10 minutes. So you should know a little bit more in detail on PLCO study, ERSPC study and prostate cancer risk management program. Your numbers with ERSPC are good. It's not accurate, but if you say 500 odd, that's more than enough. You can't remember everything, but as you do again and again, try to see if you can bring out the correct numbers also.
Yeah,
Sometimes
570 and 740. Right?
Yeah, so yeah, 570 and compared with 742 at 13 years. So the numbers will come automatically, but don't strain for it, because you should have a very smooth travel in the exam preparation also. There is no point in remembering too many numbers in one table but not remembering an important point in another table. The first aim is to make sure that we are absolutely confident in mark 6 in all the tables. Then slowly you can top it up with more points, more values, everything as we go on. You can bring in the Wilson-Junger classic screening criteria whenever anything screening is discussed. If you bring in, examiner may ask about it. Even if you say few of it, sometimes examiner will be happy to stop from there. Otherwise, I'm quite happy with the findings. You have anything to add, Sachin?
No, Mr. D, I probably should have added Wilson-Junger criteria when you asked for the screening. I just remembered now.
Yeah, that's okay. So can we continue with one more scenario?
Yes, please.
Okay. Your time starts now. Let us continue with the same scenario, and the scenario will start like a 64-year-old gentleman presented with increased PSA 5.9, repeat PSA is 6.5, and hence you have ordered for multiparametric MRI. What is multiparametric MRI? Why are you doing multiparametric? What is the meaning of it?
First, multiparametric MRI is MRI scan for the prostate with the multiple parameters, which is T2 weighted imaging, diffusion weighted imaging, along with ADC and B value, along with gadolinium-based dynamic contrast enhancement. T2 weighted imaging gives us more value on the transitional zone lesions, DWI, and apparent diffusion coefficient, which is ADC, gives us more value on the peripheral zone lesions, and dynamic contrast enhancement gives us more knowledge about tumor enhancement, early enhancement of the lesion. So these, the multiparametric MRI before any biopsy was introduced after a large multi-center RCTs, mainly PROMISE trial and PRECISION trial. In PROMISE trial, the MRI scan, all patients, about 500 patients had MRI scan followed by truss biopsy, and which was compared to standard of template biopsy. This showed there is high sensitivity in MRI scan underwent people with 93% highly sensitive, negative predictive value of 89%, and having an MRI before a biopsy could, 1 in 4 can be ruled out, which is 25% may avoid biopsy. And this was again was confirmed in the precision trial where MRI scan was compared to MRI scan and trus biopsy was compared to standard trus biopsy, and MRI scan and trus biopsy showed more cancers which are clinically significant, about 37% when compared to standard trus biopsy alone, which was 26%.
Okay, so your patient's biopsy or the MRI scan is reported by using a score. What is the importance of that scoring system?
Yeah, it is based on PIRAT scoring, which is prostate imaging reporting and data system, and also another score called Likert score, which also involves MRI with clinical finding as well. Basically, PIRAT score involves 1 to 5. 1 and 2 shows very unlikely and unlikely for prostate cancer. 3 is equivocal, and 4 is likely, and 5 is very likely. These data come from, again, the Protect trial, where the PIRATS 3 lesion showed 12% sensitive for 12% positivity for prostate cancer, compared to PIRATS 4, which showed 48%, and PIRATS 5 showed 72% sensitivity.
Okay, and your patient's MRI scan has showed PIRAT 4 lesion in the left peripheral zone. His prostate volume was 50 cc. His PSA density was 0.16. So it is radiologically T2N0M0. What will you do now?
This patient now has got high PSA density with highly abnormal likely lesion on the prostate. So I would counsel this patient for further prostate biopsy. In my clinical practice, we do local anesthetic transperineal biopsy.
So could you take me through the procedure?
Yeah, I would consent the patient on according to Bau's information leaflet and the Bau's consent form. I would inform him about the procedure involved, the risks and benefits of the procedure. Basically, procedure involves transrectal ultrasound scan in patient being in supine and lithotomy position. After all the initial check and WHO checklist as well. In the transrectal scan, I would want to check for axial and sagittal view. After giving local anesthesia in superior-lateral anal place about 1 centimeter from the anal verge, I would then go on to insert a 14-gauge access needle and do biopsy according to Grinsberg protocol, which would involve 12 set of biopsies from one lobe. That would be 24 sets in total, and taking 4 cores from the lesion, which is called targeted biopsy as well.
Okay, so totally how many cores you are planning for your patient?
If there is no lesion, it will be 24, and if there is a single lesion, it will be 28 cores.
So if there is no lesion, 24 means it will be 12 on each side, all 12 on the peripheral zone, is it?
No, it would be anterior, middle, and posterior according to the Ginsberg protocol. 4 from each areas.
Okay. And as I said, your patient showed PIRAT 4, so you will be doing some target biopsies also.
Yes, please.
Okay. And the histology of the prostate biopsy arrives as 2 cores positive for Gleason 3+3 equal to 6, and rest of the cores were benign. What are you going to do now?
This gentleman falls in the group of ISUP score 1 and the new criteria on the NICE guidelines, as per the NICE guidelines, which is Cambridge prognostic group 1. As per the NICE guidelines, I would counsel this patient after an NDT seeing him in the cancer clinic with the CNS nurse, that he would be eligible for all the options, with the primary offer would be for active surveillance. And I would mention more about active surveillance, risks and benefits of active surveillance according to the BAUS guidelines, and also about from the prostate cancer UK leaflet.
How will you risk stratify the patients with localized prostate cancer?
Risk stratification would be according to the PSA less than 10, Gleason score 3+3, and clinical staging of T1 to 2A falls in low risk, and intermediate risk which is PSA more than 10, Gleason 3+4 equals 7, and T2B falls in intermediate risk. Anything above that will be high risk and very high risk group. A high risk would involve a PSA more than 20, Gleason score of 4+3 or more, and clinical staging of T2C would be involved. And anything more than that, which is T3 and PSA again more than 20, and Gleason score more than 8, 8 would be involved in the very high risk group, which is locally advanced prostate cancer.
Okay, so you have discussed this patient's histology in the MDT. What is your next step?
After the MDT, I would see him in the clinic with a clinical nurse specialist. I would explain him about the further management plan according to his current risk. He falls in the low risk group. I'll mention it to him, and then I would provide more information about all the options involving active surveillance and radical treatment, which is radical radiotherapy and radical prostatectomy. At this point, I would stress on highlight on active surveillance, which he would be good to offer at present. And follow up his PSA in 3 months' time, according to the active surveillance guidelines, with the PSA kinetics every 3 months, and do a digital rectal examination in a year annually, and 12 to 18 months between that, I would organize an MRI scan as well, depending on which he might need a rebiopsy.
Okay, the 10 minutes is complete. We will continue the same scenario anyway, but I want to stop exactly at 10 minutes so that you will know that that is 10 minutes. And good speed. I will not say that you should have gone a little bit more in completing the active surveillance. I have at least another 3-4 questions on active surveillance. It is nice, but at the same time, I don't think you can reduce your answers in any of the previous questions also. Your pace is good, it's not slow. So I don't think you need to change anything on your communication or presentation. The only one thing I have noticed is the PIRAD, what we are discussing is PIRAD version 2. So you can discuss the PIRAD version 2. You can bring in what is the difference between the Likert scoring system and PIRAD version 2. Again, if the time permits, because that's a very interesting and new concept. You can bring a little bit more points on the Cambridge risk stratification because it's very new. A lot of candidates may not know that. Since you have studied, you can use the opportunity to say like we know about this new Cambridge risk stratification released in this date, in this journal, etc. And the main criterias, it is new. Only just 1 or 2 criterias where it differs from the previous NICE guidelines criteria, so that will give you a very good score, pushing you towards 8. That's a good idea. Anything you want to add before we go for the next scenario? We can do one more.
I thought about Cambridge prognostic group criteria, but to explain that it would take at least 2 minutes. I thought I would stop there.
Yeah, I mean, for example, this Wilshire-Junger criteria in the previous discussion, you can skip because it's a very, very old one. Just mentioning the name is enough. I don't want you to take that into detail. It may not score any extra point. But this Cambridge prognostic criteria or risk stratification is a very new one. Any new one, you should get the chance to expose your knowledge. So the steps how you are approaching the exam is, first approach is to tell exactly the answer for the question. Second approach is to bring something which you know. At the same time, the examiner should not think, why are you bringing that? I'm not asking something related to that. So it should be slightly related to it and try to bring in something new. And if it is something like a latest one, try to spend 1 or 2 minutes extra. I'm very sure if you discuss Cambridge risk certification a little bit in detail, not the full detail, just what is the main difference it is compared to the previous one. To be frank, not much. So if you are able to bring that, that will give you more points. While if you are discussing the Wilshire-Junger criteria, unless examiner asks, you don't have to tell the 10 points. It is waste of time. If you just say the Wilson-Junger criteria is the one which is used to find whether a particular disease is suitable for screening, unfortunately, prostate cancer is not suitable by the criteria. You can just stop there, unless if the examiner really wants to ask, which is quite rare because it's an old one.
Sure.
Can we continue the same?
Yes, please.
We'll do one more scenario before we finish today.
Sure.
Okay, so this patient, you have labeled him for active surveillance. What advice you will give before he goes home? And what is the evidence behind your decision on active surveillance?
The advice would be according to the NICE guidelines, which is PSA surveillance every 3 months, along with PSA kinetics, which is PSA density and PSA velocity. At 1 year, we'll do a digital rectal examination, and between 1 year and 18 months, we'll repeat an MRI scan with, depending on the results, for the biopsy if there is any abnormal lesion. And the evidence comes from a Canadian study, which is Klotz et al., which showed 99% patient had overall survival and disease-specific survival as well. However, in the same study, there were about 1/3 of the patients went on to get curative treatment during the course of the study.
Okay. So you are following the NICE active surveillance guidelines, and is there any point at which you can discharge the patient back to the GP?
I'm not aware of any criteria of discharging back to the GP. However, it also depends on the local CCG and the agreement between the hospital and the CCG. If the patient has got stable PSA kinetics, and no abnormality in his MRI scan after 1 year, according to NICE guidelines, it says that we can repeat his PSA 6 monthly, and if the CCG, according to the CCG agreement, they can be discharged back to the GP with the threshold of PSA density and velocity and PSA highlighted to the GP to re-refer back.
What is PSA density?
PSA density is PSA divided by PSA volume, and PSA volume is calculated by height, width, and height, breadth, and width times 0.52. Okay. And abnormal PSA density is anything more than 0.15.
Okay. And you said about PSA velocity. How will you calculate it?
PSA velocity is calculated using at least 3 PSA levels done 3 months apart, and usually I calculate that using PSA velocity calculator online. Okay.
So you are following up this patient. At what point you will interfere in this patient's management?
This depends on the patient factor and the PSA velocity, MRI scan, and rectal examination. If the patient at any point in the future would like to go for radical treatment, that would be one option for further treatment for radical treatment. Secondly, if there is any abnormal DRE, digital rectal examination finding, if there is PSA kinetics going PSA density doubling less than 12 months, or PSA increase between each PSA test more than 20%, or 50 PSA more than 50% in 12 months. Also, PSA velocity going more than 0.6 to 0.7 would be further indication for further counseling of radical treatment after MDT discussion.
Okay, so at what point, for example, there are some criteria which shows that this patient PSA is progressing and you are doing a repeat biopsy. How will you decide the repeat biopsy? How will you plan for it?
Initially, before doing a repeat biopsy, I would get a repeat multiparametric MRI scan. A repeat biopsy would be done depending on the MRI finding any abnormal lesion or any new lesions which is noted. I would do a transperineal biopsy again, and depending on the lesions or abnormality, I would take more samples from the targeted areas along with the Ginsberg protocol.
Okay, so as you remember, this patient's biopsy initially came as 2 cores positive in the target tissue. None of the other cores were positive, and both the cores were Gleason score 3+3. This patient is progressing with various PSA kinetics. You have repeated the MRI. MRI showed increase in the area of PIRAT3 lesion, showing some progression. You did repeat transperineal biopsy, which showed 3 cores positive for Gleason 3+4, and the total score is 7. And there are 2 new cores measuring Gleason 3+3, total score of 6. So how will you going to counsel this patient now?
This patient now has got upgrading of his lesion, so it means that it is the prostate cancer is progressing. I would ensure that his details will pass through the MDT and see him back in a prostate cancer clinic with a cancer nurse specialist. At this point, I would now recommend him to go for radical curative treatment, which would involve options of radical prostatectomy or radical radiotherapy, which can be external beam radiotherapy or brachytherapy.
How will you choose between these 2 modalities, radical surgery and radical radiotherapy?
Yeah, it also depends. This mainly depends on the patient's criteria, and also the patient willingness for the different aspects of curative treatment. If the patient is a young age with performance score, good performance score 0 to 1, should be offered prostatic. Should be offered all options, as there is no difference between any overall survival or tumor post-treatment tumor matrix. This again coming back to a point that this depends on the patient's willingness as well. If the patient is fit, if the patient is not fit for surgery, then he would be guided towards a radical radiotherapy.
Okay, so patient is fit for radical surgery. So what is your option? What is your next step?
So I would then explain the patient about radical prostatectomy, options of radical prostatectomy involving open, laparoscopic, and robotic. And in UK, we do robotic assisted laparoscopic prostatectomy in most of the centers. I would explain him evidence behind this, which would be coming from the UK largest trial, a multicentric randomized trial, which is PROTECT. Trial which showed a significant overall survival and cancer-specific survival in intermediate risk cancer, which he has got at present. I would, in our practice, we do robotic assisted laparoscopic prostatectomy. I would explain him about the procedure along with the Bow's information leaflet, and then consent him accordingly at present.
So what is the evidence for robotic assisted radical prostatectomy?
I'm not aware of the, I'm sorry, I can't recall the evidence behind robotic.
Okay, there is no need to mention the evidence, but why you are selecting robotic rather than open or laparoscopic approach?
Robotic gives, first of all, it's a minimal invasive procedure, less blood, bleeding is less blood transfusion post-operatively, early recovery for the procedure, and post-operatively there would be less incidence of incontinence and erectile dysfunction when compared to open procedure.
Okay, and how will you follow up this patient after radical prostatectomy, and what is your main criteria in the follow-up?
In the follow-up, I would like to know more. Importantly, I would like to know the histopathology results, and if there was any lymph node dissection was done according to after doing Roche formula calculation. Secondly, I would see the patient in about 3 months with the PSA repeated no less than 6 weeks post-operatively. I would examine the patient again, as just checking for the wound, any abnormality in the external genitalia, and I would want to know more about his erectile dysfunction and urinary incontinence at present. Okay. I would like to know more about his PSA level as well at this point.
Okay, we can stop now. Again, good presentation, no major concerns. Few things what we can add is you can bring in the Bow's information leaflet for active surveillance, which is a new leaflet, so many people will forget it, so you can bring that. You can utilize your cancer nurse specialist clinics. That is not necessary for the active surveillance patient to come to you every time. That will absorb a lot of the clinic space. So if you bring in that, I will use my cancer nurse specialist to follow up the active surveillance patient. You can write a protocol and give it to them. They will just follow the protocol. Or if you want to be too safe, you can make the clinics alternatively. They can see once and then you can see once. There are few times where you don't have to be in the clinic. They can just do the blood test and you can write to them. So those points will really help in get the brownie points, because that's more economical and more feasible to improve your overall efficiency in the prostate cancer pathway. And whenever you have an young patient, it's better to select the surgery because better outcomes, and patients will have a longer, better biochemical recurrence-free survival. And when you are using the robotic, you can say that there is no clearly proven cancer-related changes in the outcome, but from the surgeon's point of view, it's very ergonomical. It's good for the surgeon's joints and comfort. It gives better visualization, and as you said, there are few small points like less blood loss, less hospital stay, but overall you should bring in that there is no proven cancer specific improvement in survival just because we are using robot compared to open. So those are all the main points which you need to bring in this particular scenario.
Sure.
We can discuss this further in few more scenarios like intermediate prostate cancer and locally advanced prostate cancer. We can discuss radiotherapy and also metastatic prostate cancer. So there are good bunch of scenarios left out which we can do in the future settings. Okay?
Sure.
Good. So today in summary, we discussed how to approach a patient who is presenting with an increased PSA. What are all the nice guidelines, criteria for the GP to refer a patient? What you need to do in the initial presentation? What is the role for PSA screening? How are you going to arrange the MRI scan? What is PIRAT score, etc.? how are you going to arrange a prostate biopsy, why transperineal biopsy, and how are you planning the biopsy procedure. Once histology is available, how are you going to risk stratify? And we discussed only the low risk prostate cancer, role for active surveillance, various protocols and follow-up, and in case patient needs surgery because of PSA kinetics heading towards the wrong direction, how are we going to plan the surgery. So we stopped till now.
Sure.
In the next class, we will discuss a fresh intermediate risk prostate cancer and high risk prostate cancer, metastatic prostate cancers, and possibly castrate resistant prostate cancer. We may be doing it in 2 sittings rather than in 1 sitting. Let's see how it goes on.
Sure, Mr. D. Do you have any time in mind, Mr. D?
Yeah, I will let you know. I will message you and then we'll fill it out.
Okay. Right. Thanks, Mr. D.
Anything you want to add before we complete?
No, I think it was a good session, Mr. D. Thank you so much.
Good.
Thanks for your time.
Best wishes. See you later.
Yeah, thank you.
Bye.